Hi, Campfire. This is Dr. Bobby Parmar again. I'm really excited today because we have Dr. Romina Reyes, who's invited us to a Lifelabs processing facility, essentially in Surrey, where she's given me a tour that blew my mind for so many different reasons. I want to go over some of the things that we talked about for you. I have Kendra Burns sitting over here in the background. Hi, Kendra.
Hi, guys.
Dr. Reyes is the clinical director of this particular lab or of Lifelabs in general, I think.
For Lifelabs BC.
Yeah, okay, great. So somebody who knows a lot. And we have so many questions about infectious disease and microbiology and natural medicine. It's one of the it's coming to the forefront as one of the things that we're looking at because so many patients are presenting with interesting things that might be infectious or microbiome in nature. And we have a lot of questions for Dr. Reyes. Thank you so much for allowing us to interview today. I'm so thankful for it right off the bat. Thank you.
Well, I just want to say thank you, Bobby and Kendra, for the opportunity. It's been great to show you the lab and what we do, and the door's always open, so come back.
Really good to know. Thank you. Okay, so we're going to start talking about some of the things that you had as questions and some things that I had as questions. The first question I wanted to ask is about you personally. Why do you do what you do?
What do I do? Well, I'm a lab doctor. I'm a medical microbiologist, which is a subspecialty within lab medicine. And early on in medical school, I realized that I loved infections, but I didn't love patients.
Oh.
And so, I was actually flabbergasted to find that there was such a specialty that kind of gave me the best of everything. And so, I've been in the diagnostic world for about a decade now. And yeah, to this day, I love the infections we see, and I love the support we provide, and really, I love interacting with clinicians and practitioners, but still not so much with patients. So it's a perfect balance.
Yeah, you found your niche.
I did. Weirdly, it existed. Yes.
How long were you practicing prior to that with patients before you realized?
So zero. So
okay.
I started medical school and realized that physicians deal with patients all the time. Mm-hmm. And someone said, well, yeah, why else would you go into medicine? And so through medical school, I did all my rotations, everything from pediatrics to emerge to plastic, you name it. And every rotation, I thought, okay, this is going to be the one. I'm going to love psychiatry. And then it finished like, okay, this is going to be the one. I'm going to love emergency medicine. No. Anyways, and so I stumbled onto this field of lab medicine and haven't looked back since.
Brilliant. Okay, we're going to get right into the questions. Can you walk me through how the lab does culture and sensitivity? When a sample is submitted to the lab, how do you test against different agents, and how does resistance reporting work?
Okay, perfect. Thank you. So I think you can answer that question too after today's
now
tour,
I can.
Right? So, okay, well,
we'll just see if you trust me more than her, though.
Right. Yeah. So it all starts with a good sample collection, and it all starts with the right sample collection. And so if you are collecting something on a swab, then what we need in the lab is the pus. Pus is good. That's where all the bacteria are. And so for anything that requires a swab and culture that way, the more pus and goop you can give us, the better. Mm-hmm. So that's one thing. So it's really about how well the sample is collected and how precise you are in the collection. Some samples are a little cleaner, so some samples are collected at home by the patient, which makes it a little bit harder. Because then we don't have you in control of getting us the right sample. So for example, urine is a great sample. It's usually a very clean sample. Patients can understand it quite well, so it's no problem. Stool, a little bit more messy. Again, really patient dependent about whether we get enough, whether we get a clean stool that hasn't fallen into toilet water and stuff like that. So a lot of that is a little bit more difficult to manage. All that to say is if there's ever a question on how to collect a sample or what type of sample you need to diagnose a certain condition, give us a call because we can guide you. So it might be that we will guide you to a certain type of swab. So for example, if you want to do a virus culture, that's a different swab than you would use for a chlamydia culture. Okay. And so it's a very complicated world out there, but we're here to try and facilitate that. And the reason it's different, the reason we have so many different types of swabs and containers and tubs is because each of those things is optimal to getting us the best sample possible to give you the best result possible.
Yeah, one of the things I've learned today definitely is the idea that things have to be just right in order for you to really be able to provide a confident answer about what's going on, and that maybe a lot of the times one of the things that MDs use a lot is a lot of different labs, a lot of variety labs, and that maybe our understanding of how labs work can offer us a little bit more insight into whether or not the results that are coming back are effective or appropriate or usable for the person in front of us. And I think one of the things I learned today was there are so many variables that go into that have to be considered rather than just here's a result for something.
Right.
Yeah.
And so, as you say, so all the labs will have different swabs, different collection techniques. And so you just need to make sure that you're using the right swab for the right lab, really. And then once, basically in the microbiology lab, we're growing things. So, or we're looking at organisms. And so there's a lot of importance to make sure that when you take a sample from a patient, that the bacteria don't die. Which is why we suggest certain swabs for certain things. As you saw, some of our testing is now by PCR, so that requires a very different sample collection. Those swabs are actually meant to kill the bacteria so that the DNA is released into the liquid and stabilized. So you can imagine if you actually you wanted to grow bacteria and you put it into that container, you'd actually be killing the sample. And so it's all very dependent that way. So as I said, so in microbiology, most of our stuff is still culture-based, which means that we still need to grow an organism. Now, I didn't bring a plate because it's kind of biohazardous, and I didn't want it in my office. But you saw the agar plates where we actually are growing bacterial colonies, and then it's from those bacterial colonies that we do the interpretation. So is it normal flora? We do the identification, and then if necessary, we'll do the antibiotic susceptibility test.
Can you tell us what antibiotic susceptibility testing is? So I've just seen it, but I want everybody else to know sort of the process that goes.
Sure. Yeah. So antibiotic susceptibility testing is how we determine for any given bacteria what antibiotics may be effective in killing that bacteria or an infection, presumably. So what we need for that is we need a healthy culture of bacteria that we've isolated so that it's pure, because I can't test a mixed culture. It has to, if I'm trying to get the antibiotics for this E. coli, it has to be a pure E. coli. And then most of our antibiotic testing is automated. So from the culture of E. coli, we then have to inoculate a broth. And we talked a little bit about in the lab, at least in this kind of diagnostic lab, all of the very strict regulatory requirements that we have. And it goes from everything from the swab that we provide you guys to how things are transported into the lab. And even when we're doing antibiotic susceptibility testing, we have to make sure that we inoculate the exact concentration of what we need of bacteria into the testing panel. So we will inoculate a testing panel, and it's automated, as I said. It's about an 8 to 12 hour process in the machine. And so what the machine does is it warms up the bacteria to get them to grow. Because remember, bacteria like to grow at 37 degrees, which is our body temperature. So as you saw, all of the stuff in the lab is at 37 degrees. Our incubators, our AST platforms, all of that.
We are the petri dish.
We are a petri dish inside. The only thing that saves us really is our skin, right? Because the moment anything touches our mucous membrane, it's like direct inoculation, right? So in these panels, we test about 30, I want to say about 20 to 30 different antibiotics for that particular bacteria. And then we let it incubate for about 12 hours. And really what this machine does is it tells us what the minimal inhibitory concentration is of that antibiotic to kill that bacteria. And at that point, that's where our parameter for resistance is. So if the antibiotic can kill the bacteria, that means that the bacteria is susceptible. If the bacteria continues to grow in the presence of the antibiotic, it means that the antibiotic is not killing it, and that's where we would call a resistant bug-drug combination. So all that to say, we test a lot of antibiotics, but as you notice, we don't list all of those antibiotics. We're actually very stingy in what we report out. We usually will list out about maybe 4 or 5 antibiotics, but we have another 20 in the background in our computer system. And there are a variety of reasons for that. One is that, for example, in children, we don't release tetracycline because it can cause damage to the teeth. We don't release gentamicin because it can cause damage to the kidneys, for example. In pregnancy, so if we know that the patient's pregnant, we don't release the fluoroquinolones because that can cause problems in pregnancy. And so we have a lot of stuff in the background. And we also really try to focus the antibiotic to the wound site or the infection site. So if it's a urine culture that we're doing from a urinary tract infection, then we will not give you antibiotics that do not penetrate the bladder. Because even if you gave those, and even though the bacteria can die with those antibiotics, they're not going to get into the body site that you need. So we do a lot of that background filtering, and we give you what we think is the most useful information that you can use. But if you ever need any more antibiotics, or you've forgotten to tell us that the patient's allergic to something, you can give us a call and we can look into the back sheet and help you out.
Yeah, so essentially you're protecting clinicians from making sort of shotgun decisions about something that they feel like you said that they could use, but you're holding that back so that we don't just want to prescribe the thing that you're showing up on paper, because it might be one, bad for that population, or two, inappropriate to kill that particular bug where it is.
Exactly.
Yeah, that's one of the things I didn't know, and another thing that I took away from today is write down what your patients are allergic to, because the lab's interested in that kind of information, because if they don't know that, they're going to give you the agent that the patient can't use and then hold off on telling you other things that that patient could be using instead. So always write on the requisition form, essentially, allergic to penicillin or allergic to whatever it is.
Yeah. There's a lot of Septra allergies.
So then you just won't even report that.
I think we will report it, but we'll give you more.
Yeah, okay.
Right.
So 4 might not be 6, or 4 might not be 8. Okay. Exactly. Is there, so one of the other questions that we had is, so that's antibiotics. Thank you for the explanation. Certain labs offer sensitivities of herbal agents against specific organisms. Why does Lifelabs not do that?
Right. So all of the antimicrobials that we report are antibiotics. We don't veer away from that for a variety of reasons. Probably the main reason is that the manufacturer or the company that we use for the testing doesn't include those substances on their card. It really just includes the Cipros and the penicillins and things like that. It doesn't include anything outside of that. And then the second reason is, even if we were to do it manually, we actually, at least in this type of diagnostics lab, we don't have the guidelines and the published literature to support breakpoints for substances other than antibiotics. So I wanted to show you. I told you I was going to play show and tell.
Yes, please.
So this is our manual of how to report antibiotics. What it is, it's a compilation of bug-drug combinations, and what they've done is then they look at different antibiotics, different concentrations, how they're impacting the bacteria, and correlating that with resolution of clinical symptoms. So these are huge studies. These are huge studies that not only link the bug-drug data, the lab data, but then also to outcome data.
Yeah.
And so all of our antibiotic results are really centered around the concentration of the antibiotic in the body or in the serum. And so this is how we test, and this is how we interpret our antibiotics. So the camera can't see it, but these are the testing conditions. So every single parameter is listed for our testing condition. Right. The temperature, the atmosphere, how much concentration of the organism, what organisms do you use for quality control, what is the concentration of the drug. Then we get the drugs listed by class, and then we have the different interpretations for MIC, and that, the sensitive, intermediate, resistant, has been correlated with clinical outcome. And so as you can see, it's very, very prescriptive, very regulated, and it's by bug. So this one is for Neisseria gonorrhea. If we go to, Staph aureus, it's a whole other set of parameters and guidelines that we have to test. And so we don't have this for natural substances or other substances that are not antibiotics.
And so that if a lab is reporting that berberine is effective for treating bug A, let's say the E. coli, that they might not be using the same kind of rigid standardization and background to confidently say that thing will actually do its job against this, because the standard isn't there. How it killed it, how much did it kill it, after how long did it kill it in this particular amount in this plate, which is not necessarily the same that you would be taking as an extract of that thing. There's just too many variables, essentially. and this handles most of those variables for drugs.
For the drugs that we know.
Okay.
Yeah.
That's really helpful to know. Like I already asked you this before, but it's really helpful to know because we test for things all the time, and as naturopaths, we want the natural substance to be the thing that kills that thing. We'd rather not use a drug, even though most of us have prescribing authority, but you still want to avoid that. And if somebody's giving you permission to be like, oh, you could use this, you feel in your brain, like, you know, you're withholding these drugs from certain samples for a reason so that you're not letting clinicians think I can use that when it might be dangerous. But we're not getting the same thing necessarily from herbal therapies because who knows if it might not even work. You might give it to a patient and 6 days later you might think, why is this not working? Or they might get better. But did it actually get rid of the infection that they actually had? Was there something else going on? Just too many questions for it to not be like A went to B. Okay, I guess.
And so it's even murky for this kind of thing, whether A is going to be. But there is, you know, there's published documentation, there's literature that we follow. Again, it's very different if you're ingesting an antibiotic and expecting tissue level penetration versus taking an eye drop of clindamycin and putting it in the eye, right? That concentration of antibiotic given directly onto the eye is a very different concentration than if you were to take it orally and then expect from the inside that concentration to go to the eye. So all of those things impact levels of antibiotics.
So one of the things I think we think, and this is bringing that question up for me, is our trust in the reliability of labs. That this kind of stuff adds to the reliability of the information you're getting. Then we always see patients who are, looks like they're clearly infectious, and you're like, this is an infection. And then you send them for infectious disease testing, and it comes back negative. What are we supposed to do with these patients?
Right. So I guess that's a tough one, and I think as a practitioner who's actually seeing patients that you, not me, I only get the specimens later down the road, but really history is very important, and the clinical exam. So are there signs of infection? Are there systemic symptoms? Is there fever? Is there heart rate elevated, etc., things like that. The second thing to think about is, did you take the right specimen?
Yeah.
So, for example, if I'm just going to give a very honest example, but if you feel they might have a respiratory infection, you don't do a throat swab, right? You actually need the pus that's coming from the lung. So did you take the right sample? If you did take the right sample, or you sent the patient away to take their own sample, did they do it correctly? So did they put the sample in a tube or a tub or something that's actually going to, so is the bacteria alive when we got it? So sometimes there's a lot of confusion with a lot of stool testing because one of the tubs is actually for parasitology and it contains formalin. Now, formalin kills bacteria. So if they accidentally put the stool for the bacterial culture into the formalin jar and then switch the caps, we're not going to grow anything. And we're going to assume it was. So those are some of the pre-analytical issues that you might face. If it's negative, so two things that's, I think, really important from the lab, depending on what kind of sample. So if it's a sample where we did a culture, 90% of the time we also do a gram stain for you, which we didn't really talk about a lot today on the tour. But the gram stain is your first indication of whether or not the sample was good and what might be going on in the patient.
Okay.
So, for example, if there's a wound and you've taken a good swab from the wound, say you just took a superficial swab from the wound and you submitted it, on the gram stain, what you might see is epithelial cells, no neutrophils, no pus, no bacteria. So you want to think, did I get enough sample onto my swab?
Okay.
If you do a really nice deep swab, what you're now going to likely see is and the squamous epithelial cells, that's on the surface of our skin. And so if you take a really deep swab, you may not get any of those squamous epithelial cells. But what you might see now is 3+ neutrophils, which means there's a lot of inflammation, there's a lot of pus. You might see a lot of bacteria. So that's an indication that it was a good culture. So we see that often.
And you do that automatically?
We do. We pair the gram stain with every culture. We don't do gram stains for urine cultures because that's a urine specimen, and we don't do gram stains for throat cultures because in the throat we're only looking for one pathogen. But for and we don't do it for stool cultures because there's a lot of stuff in stool, and basically the gram will always be black. You wouldn't even be able to read it. So that's a great correlation to see if the specimen was adequate. And then you can correlate that with the culture results. So we see a lot of, and sometimes we'll put an NSQ, non-sufficient quantity, when we don't see the cells that we're expecting. And we get that a lot from like vaginal cultures, where there's just nothing on the spot, and nothing grows. And so is it because there was nothing there, or is it because the specimen was not great? So that might be some reasons. The other reasons you might have a negative culture, even though you truly suspect it's an infection, is that it's a virus. So we don't culture viruses in this lab. Remember, we only culture bacteria. We do a little bit of mycology for dermatophytes, but we don't do any virus cultures. So if that lesion on the hand that seems to be red and infected comes back culture negative, it could be a virus. It could be zoster, it could be herpes, and we wouldn't know. We basically can't culture it if it's a virus. That might be another.
One of the other things that was brought up that is sort of in a similar vein is we use a lot of urinalysis done in-house with dipsticks, and that when you send out a sample for culture, the question is, do we send out a sample for a culture? Is the dipstick good enough? And a lot of dipsticks come back seemingly positive. And I really liked your answer earlier because it helped me understand that better. So please help me understand it again.
Okay, so urine cultures are quite difficult, and because they're easy to obtain, so there's that reflex. But really, what I said earlier on is that it's all about history. Are there symptoms? Symptoms will trump a dipstick any day. History will often trump a culture any day as well. So, does the patient have dysuria? Is there pain on urination? Do they have hematuria? Is there blood on urination? Do they have frequency? So, are they going really frequently and only coming out with a few drops each time?
And that's not normal for them.
That's
because
not
some people
normal.
just pee a lot.
Exactly.
Yeah.
Exactly. And some people drink a lot of water, so they're always in the washroom. So those symptoms are key, and those are the typical UTI symptoms you think of. If you're worried about more of a systemic infection, so pyelonephritis, you're thinking about fever. Does the patient have fever? Does the patient have costovertebral ankle tendons? Okay, so history, physical are super important. Now the dipstick. So the dipstick is a very non-specific measure of what's going on in the urine. I would say for bacterial culture and to correlate with culture, probably the most important marker on the dipstick is nitrates, because the human body does not make nitrates. And so often it's nitrate being cleaved by gram-negative bacteria that will make the little nitrate strip light up. White blood cells are a little bit more difficult. Yes, they can be there in a UTI, especially if there's pain on urination. It might be that there's inflammation, but it can also be caused by many other things. Was the patient catheterized? Has there been any trauma to the area? Have they started using new soaps? New dishwashing detergent? Is there something irritating in the urethra? That could cause white blood cells to be present, but not mean that there's a UTI. And so really a lot of it is about the symptoms, what they're presenting with. And also the dipstick is not a very predictable marker of UTI. So 50% of the positive urine cultures that we see have a negative dip. And then 50% of positive dips or negative dips will also have a positive culture. So it doesn't always correlate. But I bet if we went back to symptoms, we'd be able to tease it out.
Yeah, I really wanted to repeat that because I didn't know that, which means a lot of people didn't know that. And if we're relying a lot on in-house dipsticks to assess somebody and we stick to the leukocyte strip, and we think, wow, that's really positive, 3+ or something. That doesn't actually mean that much. The reason you did it is probably because the patient was complaining of something, but maybe that complaint isn't necessarily related to them having a urinary tract infection that you're going to treat with an antibiotic or an agent like that. That maybe a culture would be appropriate to try to figure that out. Unless they have nitrates, then would you be like, okay, the dipstick is more confident then?
Yes.
Okay.
But I would still do a culture.
Okay.
Because sure, you can send them home on empiric therapy, and you can use our antibiograms. I hope you've seen those. Maybe we can talk about those next time. But you can see our antibiograms, and so you can see, like in the community, what percentage of E. coli are still susceptible to nitrofurantoin, and then you can see by organism what is the best likely therapy. So you can start empiric therapy. Send us the culture. We'll give you the real answer. And so if it happens to be sensitive to what you're treating the patient with, no problem. But if it's resistant, now you know you
I know that a lot of times labs report, like obviously culture sensitivity, we ask for them. But in literature, you'll find that guidelines suggest use this antibiotic unless you're in a highly resistant
Yes.
area,
Yes.
and that you basically bypass that by doing the culture sensitivity
Yes.
because the lab's going to tell you what that specific bug had a drug in terms of effectively killing it.
Right.
Yeah. Okay.
Exactly. So for that patient, we will give you a result for your patient.
Yeah.
So when guidelines say unless a highly resistant area, they're alluding to the antibiograms. So an antibiogram or a bug drug combo that has more than 5% resistance in the community or in the setting. So if you're in a hospital, it's slightly different. If you're in a community, it's a different thing. Then that would not be your first line empiric.
That's such a low threshold.
Yeah.
But meaningful.
But very meaningful. Yes.
Okay.
Yeah. Because empiric should mean it should cover 100% of the people. So the moment you start seeing even 5% resistance, you should probably do something else.
In my brain, it was like 80% of people are not responding to this, so you should probably not use that. But it's the complete opposite.
Right.
Yeah. Fascinating. Okay. Next question. Parasite testing returns negative. The patient claims even seeing worms in their stool.
Mm-hmm.
I have seen this personally dozens of times.
Right.
Last week, patient snaps a picture of clearly a worm and then sends a sample on another day and says, there's something in there. What do we tell these patients? Is it something similar to what you just said? Being like, just keep trying to test it, or
Okay, so I think if there's a worm, okay, so it's a little bit of the details of the lab. If the patient actually has a worm and can isolate the worm, send us the worm, and we will identify the worm.
Okay.
If you just send us stool, remember I showed you we process the stool very aggressively. In half of the stool gets turned into a blue slide, and the other half gets this sort of brown slurry. If there's anything huge, it's not going to come out in the brown slurry. So the thing is, we don't dig through the stool to look for worms. And so if you're looking for ova or parasites, so the parasites are those tiny, tiny protozoa that we saw through the microscope that are impossible to see. Okay, a worm is going to be too big to get onto that slide. And then we're looking for eggs and worms. But when we say worms, we're looking for tiny worms, like almost microscopic worms. So if your patient actually can pull out the worm, they can just wash it and send it to us and we'll identify it. Because our O&P testing will not pick up large worms.
Send it to you in what?
In a tub, anything. If they have an orange top container, that would be ideal.
Okay, so it doesn't have to be in some special medium or anything.
Nope.
Just like dead worm, here you go.
Yeah, we will kill it when it gets in the lab. It's probably still alive when they send it to us, but we'll just drown it and process it. And yes, so that's interesting. So I was thinking about that question, and the reason we may miss those kinds of worms is because we're not doing the right test.
Yeah, okay.
And we don't know, right? We have a policy that we don't dig through stool. We used to, but we don't anymore.
Interesting.
Yes. So if there's an actual worm, send us the worm by all means, and it's actually pretty fast. Like you saw our parasitologist, Nick, who's in there. He can like smell a worm and he knows exactly what it is.
I thought it was if there's a big worm, like they're like that big in people's pictures. If there's a big worm, there must be something else testable in the stool that would identify that there's this giant worm there.
No, we need the worm bits, the worm parts. Yeah, there's nothing else we could test.
Okay, good to know. Like these are the kinds of things.
Think about pinworm too.
Yeah.
Sometimes we'll see those little tiny pinworms, and I would recommend a Scotch. It's called a Scotch tape test. So I would recommend that. But again, it's just for the worm.
The Scotch tape test, that's just sort of pressing it against the anus.
Early morning.
Early morning.
Because that's when the mother worm comes out to feed her baby.
Yeah, she's so loving. Okay. Blastocystis hominis, speaking of parasites. This is a huge topic in naturopathic medicine. Don't know how big it is in the rest of the medical world, but we see BH come back on our O&Ps all the time. Our patients, conventional doctors are like, leave it alone. I've heard that so many times. And yet the patient clearly has bloating or some symptom that they're being like, I think this could be something. You run an O&P and incidentally maybe even like it shows up. Or their doctor tested them with an O&P. BH shows up and they said, leave it alone, you have IBS. What can we do?
Well, parasites are not normal flora. Parasites should not be in us. Parasites are eukaryotic structures, and so are we. And so that means they shouldn't be just living in us as part of our normal flora. Bacteria are prokaryotes, very different kind of organism, and so we expect bacteria to live on us and inside us like a petri dish. So Blastocystis hominis, we here in the outpatient world get this question a lot from practitioners. This is the other Chantal I was going to show you. I'm sure you all have seen the Sanford guide for
No, we haven't.
infectious
Romina.
disease testing.
Show us.
Yes, and so what it says in here, which I don't necessarily agree with, is that blastocystis is a questionable pathogen. So to me, when sort of our medical guidelines say that, to me it means that you need clinical symptoms to confirm it. So now in the lab we don't get any information about the clinical symptomatology of the patient, but if I had a patient who was symptomatic and had a parasite in their intestines, to me that means that it is no longer a questionable pathogen, but that it is causing some distress in the body. And in my opinion, I would treat those. I think the medical literature is out there, and so there is literature around Blastocystis hominis and Dianthina fragilis about them being sort of the unspoken causes of many types of GI discomfort. And the thing is, there's not a lot of interest in blastocystis, so there haven't been those definitive studies or randomized control studies that have said you need to treat or do not treat. And so whenever I read that it's a questionable pathogen, to me that means it needs correlation with clinical symptoms.
So if somebody didn't have symptoms and you still ran a stool test on them because they have money, and they want to come in to see what's going on, but they don't have GI symptoms, and they would be H positive, would that be enough to warrant treatment to that person too?
So I think you would have that discussion with them. You would have knowledge of the rest of their medical history. Are they immunocompromised? Are they going to be starting biologics? Are they, what else is going around around that patient? If they're an otherwise healthy 40-year-old person with no other comorbidities, no symptoms, but a positive blastome, you can watch and wait. You can watch them. You might retest them to see if was their body able to clear it on its own, or is it still there? So I think that's where you would gauge sort of the entire picture. If there's symptoms and there's blasto, I think I would recommend treating, and that's what I recommend the doctors.
Yeah, that's good. That's all good to know. We often, as a collective medical community in the naturopathic world, want to treat things that show up as infectious disease or something in that world because with Candida and E. coli and Blasto and you name it, we always think that must be playing and calling shots on our immune responses or changing internal flora that might also be changing other things. So if it shows up, get rid of it. Or even we think that they're there, like especially Candida and things like that. So try to cleanse that out of the person's system because it might be playing a big role in them globally. And so it's always helpful to know that when there's something really questioned in the medical community at large, are we doing the right or wrong thing? And we need guidance that way because we tend to look at things always like, get it. But what if you don't need to get it?
Right.
Yeah.
And then the other thing about blastocystis that I want to add is that most laboratories still report it, which means the answer is not definitive. Because the day that labs start reporting blasto is the day that final study is going to come out, and it's going to say blasto is not a pathogen. So while you're still seeing because in the lab we do a lot of background stuff, right? We will filter things out that we think are normal flora. As I was saying, we don't always report the non-pathogenic parasites and things like that. So we do a lot of work in the background to try and digest the information and give you what's clinically appropriate. And we're still reporting blasto. Why? Our external proficiency testing still requires that we report it, which means to me that I think that there's still needs to be work. Work still needs to be done to determine where we're going. But while the labs are still reporting it, to me it's still a potential.
Do you report other pathogens that aren't connected to necessarily like clinical disease states in the ONP?
So for certain testing we do. So for most of our traditional publicly funded testing for parasites, we do not report the non-pathogenic parasites, which I think we should be doing, particularly because well water and travel and all of these sorts of things, but we are not reporting them for the publicly funded testing. For the Rocky Mountain Analytics gut well, we do report the non-pathogenic parasites because I think that patient group is different.
Yeah.
And I think that the practitioners who are requesting those tests are more open to seeing the bigger picture.
And wanting to basically, I always use this analogy, like throwing it a little wider to catch as many things as possible because this very potentially complicated person is presenting to you and likely presenting to you because they haven't been able to get anywhere else with what they normally, the avenue they normally would go down. And so the more information isn't necessarily bad, it can be helpful as long as you know how to interpret it properly.
Exactly.
Yeah.
And so we have internal protocols for the non-pathogenic parasites. So if we keep seeing in the same patient the same non-pathogenic parasite, it actually says in the tech protocol, consult MedSci, because that's when I might get on the phone and say, by the way, although we haven't reported it over the last several times, your patient has significant parasitic load, right? So we do a little bit of that internal stuff for the general population, and so it is in the protocol because you should not be colonizing parasites.
There's this thing about sort of you mentioned different labs, and there are a lot of other labs that we use. Lots of like chronic infections labs. IGenics is one of them. Armin is another one. And I really like your take on this. Can you comment on your understanding and your knowledge of these other private labs and other places that we go to help us understand what's going on from infectious disease?
Okay, so I think the key point around labs is sure there are going to be labs everywhere, and there are general labs like this one that you've just seen, and then there are specialty niche labs like IGenics does Lyme testing, and then there are labs that do even the 23andMe, right? That's its own lab in itself.
Yeah.
And so I think really what's important for practitioners to know is that every lab can produce a result. Every lab can produce many results, but how much can you trust in their process?
Yeah, that means everything to us.
Right? And so a lot of that is around accreditation and licensing, etc. So labs like the ones you typically will see in Canada, we're all accredited either by provincial, national, and international standards. As you saw, everything is uber regulated, and there's no art in lab medicine. It's all very protocol and guideline driven. And so some of the labs in the United States, for example, like IGenics, is a CLIA accredited lab. It's a CAP accredited lab, which is a national accreditation body, which means that lab has to maintain, adhere, meet, and excel on standards that allow for it to be producing correct results. Not all labs may have that. And so I think, as a practitioner, we have the responsibility to have a look at these labs. Are they accredited? Who are they being accredited to? What standards? Who's on their, who's running the lab, right? Is it a kid with a Bachelor of Science? Or is it, a lab physician or a PhD or a scientist, right? I think all of those things matter. For the IGenics, for example, we know that they do Lyme testing, and we also do Lyme testing in Canada at a very much smaller rate. They are, as I said, an accredited lab, and you can tell even we were talking about the reporting. So they not only report their interpretation of their results with their parameters, but they also include CDC parameters around reporting. So the CDC is the Centers for Disease Control, and even for Canadians, that is the authority on lab medicine, infectious diseases, everything. And so if it's something that's coming from the CDC, we almost take that as the rule. Those are the rules that must be followed because they are so well renowned. So I think a lab like IGenics that reports both, so gives you all of the information, but then also lets you see what the CDC is reporting. Like that to me is very professional, and that allows the ordering practitioner to make a determination. So by these parameters, your patient is negative, and by these parameters, your patient is positive. Okay, let's look at the patient. What were the risk factors? What are the symptoms? What is the history? What is the whole medical environment around this patient? And by having all of that information, I think you can make a better assessment of what you need to do.
The accreditation groups,
Mhm.
are there ones that we should specifically look for?
So in Canada, it's very simple. So in Canada, there are the provincial groups. So there's in BC, for example, it's DAP. In Alberta, there's specific provincial one, and they go all the way across the country. Some laboratories, like Lifelabs, is actually also internationally accredited by ISO. So that you might see in some of the American or even European labs, you might see accreditation to the ISO standard.
Okay.
And that is basically a guideline for good lab practice. In the United States, there's CAP, which is CAP accreditation, and CLIA. So those are some of the big names that we hear around the States.
And we see that means trust.
I would say that those labs are have to meet certain standards, and are being evaluated, right? That's how a lab stays current and relevant, and it keeps their quality is by constant evaluation.
Is there
and there may be more, but those are the ones from my sort of interactions.
Yeah, okay. Okay, great. Thank you. Okay, what else? Any treatment or diagnostic pearls for chronic fungal infections? Most frequently, onychomycosis. I think somebody asked this from our Instagram.
So that's a really tough disease. You should see our we call those dermatophytes. So dermatophytes are fungus that invade skin, hair, and nails. And so in the summer, when the sun starts to come out, we get an influx of toenails because everyone's looking at their feet.
Yeah, right.
So, and everyone wants to wear their shoes over the summer. So right now, I think our dermatophytes go through the roof at about this time. So that is
hilarious.
Right? You know the weather's changing when we get a lot of nails in the lab.
Okay. It's like nobody looks at their toes
in the winter, right?
Okay.
Why would you got socks on?
True,
shoes,
quite true.
right? There's now pool parties and all sorts of things. So dermatophytes, for those cultures, we need either skin scraping, so with scalpel, or nails, so nail clippings, or hair. So sometimes there are dermatophytes that affect the hair and will cause hair loss or pinworm, roundworm, etc. And so we have special collection kits that you can send those in. Those infections are very long-standing, usually in a toenail that's infected with a dermatophyte. So two things. Toenail, the most common cause of toenail infections is actually bacteria. It's actually Pseudomonas aeruginosa. And that will cause a greenish tinged toenail change, and usually thickening. So onychomycosis we refer to as a thickening of the toenail and discoloration. And if it's green, think pseudo, think bacteria, which is a lot easier to treat than fungal infection, because basically when the fungus invades the toenail, it actually invades the skin under the toenail and down into the nail bed. And so for fungal dermatophyte infections, which you would get a positive result from the lab if it's a true one, it's often weeks and weeks of oral antifungals. So the problem with that is that antifungals are broken down like the liver, and so you need to check the liver enzymes to make sure it's reversible damage, but you need to be checking that the liver is not going to go completely haywire. And it's often 6 to 8 to 10 weeks of therapy because the nail has to grow out and the antifungal has to penetrate into that tissue and push the fungus out of the nail bed.
Is there a way to assess efficacy for that kind of thing along the way, or do you just wait for the 4 months to go by?
You just have to watch the nail grow out.
Okay.
So once the nail grows out, you should see that the new nail that's coming through is healthy nail.
Right.
So it's very, very long, because toenails grow very, very, very slowly as opposed to fingernails. So it's a really tough one. I think on the market there are also topical antifungals which may help, but remember for fungus infections, you need to penetrate the tissue. Bacterial infection should resolve quite quickly, and we will report bacterial Pseudomonas from toenails because that's usually just a couple of weeks, and you will see improvement right away.
Somebody asked about sensitivity and specificity of in-clinic screening tests, H. pylori, rapid strep, UA, we talked about the UA, whether they're good screening tools prior to sending patients for testing at BC5.
Okay, so we would say prior to sending to Lifelabs.
Lifelabs. Yeah.
So we call those point of care tests. It really is practitioner and test dependent. So in some of those tests are not very sensitive and not very specific. So, for example, there's a point of care test for strep throat. If it's negative, you still have to do a culture.
Mm-hmm.
And so a lot of those tests you may be able to use to ruling out a disease, but never to rule in a disease.
Okay.
If you had a strep throat in a child, though, where there's the possibility that they might develop rheumatic fever and heart problems, in a child you would never do a rapid test like that. In a child you would just do a culture. So it really depends on your patient population and what you're trying to determine.
Okay.
So I would use them with caution, and if you're going to implement them in your clinics, you would want to choose a test that has good sensitivity, good specificity, and that you're able to maintain good quality control, so that you know that your results are actually reliable.
Yeah, so I guess the problem. Yeah, the problem with that is trust in the reliability. Two, is it a population that needs to be figured out fast? And if that's the case, you may not want to use something that might be wrong. Yeah. Okay. Titers for infectious conditions. What is the relevance? Does everything go through Lifelabs through the CDC?
Yes. So by titers, I assume we're talking about serology.
Yeah.
So IgM, IgG to things like measles, mumps, rubella, et cetera, So all of that testing is currently done at BCCDC. Lifelabs does some of the preliminary tests. So for like hepatitis, we'll do hepatitis B surface antibody. So we do some of the preliminary stuff, and then we will send off to BCCDC to do the more complex inflammatory. I would say 95% of serology does go through BCCDC. But you can if your patient has it on a requisition, the patient can come to our Lifelabs center. We'll draw the blood, and as we discussed, we have a large system to make sure the samples go to where they need.
What is your, like, for a clinician like me, what would be a really good resource? Obviously, the schooling is what it was. What's a really good resource that you'd be like, you know what, here's what you could go explore more of this. Everything we're talking about, sort of microbiology and infectious disease, like go read this book or like this manual or online reference. Do you have anything that you're like, that's my go-to?
Okay. So I think for the clinical side of infectious diseases, my go-to is definitely the Sanford.
Okay.
And not the 2014 edition.
Okay.
Make sure you get yourself an updated
The Sanford
edition.
Guide to Antimicrobial Therapy. So kind of like that.
But a more up-to-date edition.
There you go. Yeah.
I would say this has it's a very brief overview of parasitic, bacterial, fungal infections. I think if you have access to up-to-date, I think from a management and treatment point of view, up-to-date actually provides a really good way to take a lot of information and have it synthesized for a clinician.
Yeah.
It's a little bit too general for a lab doctor, so I could never find those crazy parameters in up-to-date. But for managing a patient, I think that's pretty good. And then I think another really good resource, two more, is if you want to know about testing and who offers what tests, online there's actually a website where you can see what tests are offered in the public sector and how to collect them. And there's a website that I can give you, Bobby.
Yes, that'd be great.
It's eLab Handbook.
Okay.
So that is for the public sector. And then Lifelabs has a very similar one on our website, and it's all the tests that Lifelabs offers and how to collect them. So that would be more, you've decided what you want to do, now you want to figure out how best to do it. Those are sometimes quite useful.
Is that first one Canadian?
It's for BC.
Oh, okay.
So it's a lower mainland specific thing. So a lot of the esoteric testing that we send to BCCDC that no one knows about, we can usually Google and find. We can search it in there and find it.
eLab Handbook.
Yeah.
Okay, great. Good to know. I'll probably post that. I'll look at it myself and post it as part of this interview. Our last question is, are there exciting things about infectious disease that are coming through the pipeline? I mean, naturopaths are obsessed with infectious disease. I've said that 50 million times.
Yeah.
But what about from your perspective?
So I think, I'm very much a lab geek, and so to me it's all about technology and what's coming through and better diagnostics and how do we get at the right answer faster and better, etc. And so from that side, we are seeing a big surge in molecular testing.
Okay.
So when we were in the lab, all you saw were plates and cultures and colonies and people, and a lot of our technology is now moving towards molecular diagnosis. So when we went into the back of the lab and you could see the STI testing platforms, that's where we're thinking that the laboratory will go. for stool cultures. You may not be doing 8 plates a patient anymore. You might be putting it onto a well and putting it into a PCR machine and having a result in 1 hour, as opposed to the 12 hours or 48 hours that it currently takes. So that, I think, is something that's coming through and really developing. I think from the infectious disease world, so the more clinical world, 2 things that are fascinating to me are measles, because we're seeing measles outbreaks in the province, and the whole role around vaccination and infection control, and diseases that were old diseases are now new diseases. So that is kind of disconcerting. And then currently, I don't know if you've been reading and seeing all the headlines, but there's this amazing yeast that's got everyone in the United States in a panic, called Candida auris. And it's a yeast that grows very well in the environment. And so if an environment gets colonized, like a hospital with Candida auris, you can't get it out. You can scrub, you can clean, but you just cannot get it out. So it's okay for me and you, because we're otherwise healthy people. We're not in the hospital. But if that yeast gets into a hospitalized patient with a lot of comorbidities and causing an infection, it's actually resistant to all antifungals. So you can't treat it. So things like that are always fascinating. A little bit like the movie, those movies that we've all seen.
Well, there's every day there's something new in the news about it. Last week it was all about this frog species in the world that are being completely wiped out by a fungus that nobody really knew that existed until now we have no frogs. And so 40 years goes by and they're like, oh yeah, there's less and less frogs. And they're like, you know what, we have about 10% left of frogs in the world. And that's ecologically disastrous. Or I was just saying to Kendra on the drive here, yesterday in the news, a kind of fungal infection called malassezia that typically is known for dandruff is now being found in people with Crohn's disease. And it is, I know, and it is being isolated as only found in the intestines of people with Crohn's, but not anybody else. So could it have any bearing? Right. What does that mean? Or that Candida and E. coli are also found in people with Crohn's disease in a sort of biofilm together that isn't found in other people. What does that mean? Preaching to the choir here, but naturopaths are all over infectious disease, and I think one of the things that we need to do is, because it's at the forefront of everything that we think is going on with some people, whether it's chronic Epstein-Barr or reactivated Epstein-Barr or any of the things we talked about, is to get as well informed about the way we try to investigate it as possible, so that we're not just throwing stuff out there and then seeing what we catch and come back and then confirming our own biases. And we need to understand the way labs work in order to know that better. And so that makes you allowing for us to access your brain and your job and your lab that much more special, because it's going to help us fill in so many of the gaps that we otherwise don't have access to. Yeah, so thank you so much for this.
Thank you. And just to say, infectious diseases of all the specialties is probably one of the more straightforward, because the body will tell you where the infection is, right? So if the infection's in the bladder, it's going to hurt to urinate.
Yeah.
If the infection's in the lungs, it's going to hurt to breathe. If there's an infection in your skin, usually you'll see an abscess or some pus. So the body has a great way of telling us that there's something going on. If it's something that's systemic, so you have loss of weight, you have night sweats, you have fevers, now you're thinking there's something internal, and a blood culture would be how you would investigate that, right? So infectious diseases is really, so the infections that we get in our body are usually quite predictable and really site specific. So always use, that's why the history, and then your clinical exam are probably 90% of that. And then the diagnostics that we're able to give you a little bit more info, but you've done the hard work already. So I think it's a really important collaboration between the clinician and the lab trying to get that patient better.
That's a good reminder, because I don't know why, this might just be my bias. I would have thought you would have said before today, no, just it's what the result is.
No, never.
Yeah, you know what I mean? I would have thought the lab person, the lab doctor would have been like, whatever the result is, that's the result. Who cares about what the person is experiencing?
Oh, wow. Yes,
that's honestly what I would have thought.
That's probably what I've told you on the phone.
Yeah. and so I'm really happy to hear this sort of no, look at the person in front of you. Clearly, you have to look at the person in front of you.
Yes.
And that the lab is either supportive of what's going on, or might reveal that it's something not in the lane that you're trying to go down.
Right.
Yeah.
Yeah. I think it's an important collaboration for sure.
Well, thank you so much,
Yes, thank you.
Dr. Reyes.
Thank you very
I'm
much.
sure we'll be
Thank
seeing
you.
more of you in the future.
Yes, I really look forward to it.
Thanks, Campfire.